Hi, good afternoon, everyone. Happy Friday, all. And welcome to our webinar titled Treating Persistent Asthma, Putting Patients on the Right Therapy Using the Stepwise Charts. This is the third webinar in our four-part webinar series to celebrate Asthma Awareness Month. My name is Stephanie Espinal. I'm a Health Promotions Manager at the American Lung Association, specifically the New York State Children's Asthma Initiative. If you have any questions throughout the presentation, we welcome them. Please put them in the chat or in the Q&A box. I'll be regularly looking at those at both locations, and we can have a portion at the very end for any questions. This webinar will be recorded and will be sent out a few days after. So sometime next week, you should have access to rewatch this webinar. It is my pleasure to introduce Dr. Calliope Cyrilakis. Dr. Cyrilakis is an assistant professor of clinical pediatrics at Weill Cornell Medicine and assistant attending pediatrician at New York Presbyterian Hospital. She is also the director of pediatric pulmonology and the Pediatric Asthma Center at New York Presbyterian Queens. She serves as the co-chair for the Asthma Partnership of New York, as well as being a clinical advisor for our Project Breathe New York Quality Improvement Program, as well as our other New York State Children's Asthma initiatives. With that being said, I'll pass it over to Dr. Cyrilakis. Thank you so much.
Hello, everyone. Thank you for joining us. I unfortunately cannot see you guys, so I'm not entirely certain who's on the call, but welcome and thank you for joining us. I'm going to try to go over a whole bunch of, can you hear me? Okay. I'm going to be going over a lot of different topics today related to the stepwise charts. So I don't have anything to disclose. Oops. Stephanie, I'm not sure if you're able to mute other folks.
I'm surprised that we are getting some feedback. Yes, if you can you please mute your lines?
Okay, wonderful. So just to make everybody aware, I will be discussing some non-FDA approved usages of various inhaled steroids and ICS/LABA in particular in children of younger ages. So some of the topics that we're going to be covering today, I'm going to be describing some of the current evidence-based guidelines that exist for assessing and managing asthma in pediatric patients. We're going to really review and we're going to delve deep into the different classes of controller and reliever medications. And we're going to highlight the use of anti-inflammatory relievers, AIR, and single maintenance and reliever therapy, or SMART, in asthma management. And we're going to discuss the updated 2025 Breathe New York stepwise charts in detail, as well as applying the principles of personalized asthma care when selecting treatment options when you want to start your patients on their asthma medications. So as we all know, and I hope most of you are aware of Project Breathe New York, which is supported by the New York State Children's Asthma Initiative. This is a quality improvement project that provides the framework to engage health systems and community-based partners to integrate sustainable evidence-based asthma care coordinated across settings. So whether it's the hospital, primary care offices, community-based organizations, and really looking to educate patients and providers. And so that is why the ALA is providing these webinars during Asthma Awareness Month. If you would like to know more about the New York State Children's Asthma Initiative, you can use that QR code that is up at the top corner. And on there, you will find many of the resources from Project Breathe New York, as well as many of our educational resources. So let's talk a little bit about asthma guidelines. So we all were aware of, about almost 20 years ago now, the 2007 NAPP EPR3 asthma guidelines came out with the 4 components of asthma management, which were really focused around assessing and monitoring asthma severity and control, using the right kinds of medications for asthma control, and then also controlling environmental factors and comorbid conditions, as well as providing patient and family education for partnership and care. These guidelines from 2007 were the basis of how we all managed asthma and took care of asthma for a very long time. In 2020, the NAAPP put out a focused update, which we lovingly refer to as the EPR4, although it is technically not the EPR4, where they only really updated very specific topics, and they answered very specific questions. So it was not a general overhaul of the guidelines or an update of the overall guidelines. There was very, very specific updates that they addressed in that one. The GINA guidelines, on the other hand, which are since about 2019 have been updated on a yearly basis. This is the Global Initiative for Asthma. Have continued to be updated on a yearly basis since about 2019, so for the last several years. So there have, from the GINA guidelines and then the EPR4, there were actually some significant discrepancies between the two different guidelines that made it very challenging for a lot of providers to understand how they needed to be assessing and then managing their patients' asthma. So, and just so everyone is aware, the GINA guidelines, the latest update actually just came out last month. So a lot of this stuff is hot off the presses, although a lot of the concepts from GINA have remained the same from even back in 2019, and they've just tweaked and updated some of the details of how we manage asthma. And then they've provided additional information for certain specific topics as well. The EPR4 guidelines, unfortunately, that is the last time that they were updated, which was back in 2020. So we don't really have much new from our CDC. So the GINA guidelines and also the EPR3 guidelines from 2007 had suggested this way of really thinking about personalized asthma management, where you are assessing your patient's severity, you are starting them on some therapy, and then you are reviewing their symptoms, their exacerbations, their control. And then once you've reassessed their control, then you adjust your therapy and you just keep going around this circle. And this is the main crux of how we manage asthma, as you all know. So when we assess asthma severity and control, the EPR3 guidelines had actually suggested the two domains of impairment and risk. Impairment are your frequency and intensity of symptoms and functional limitations, like your spirometry and your lung function. And then risk is really the future likelihood of asthma exacerbations and progressive decline in lung function over time. This is typically counted as the frequency of systemic steroid use. And those two factors together will end up helping you decide your patient's severity, as well as be able to help you assess their control as time goes on. Okay. So how do we all do this? As many of you know from the Breathe New York tools, we have the Assessing Asthma Severity Classification tool, which is really helpful for helping us figure out for the different age groups based on their symptom frequency and the courses of steroids that they've had in the past 6 to 12 months, what their severity of asthma is. How do we use this tool? So we like to call it the circle tool for those of us who still do things on paper, or we have it in laminated form. And when you identify the most severe category in those questions for the frequency of symptoms, and then you work your way over, and that tells you the level of severity for your patient. This table also, we have added to the end of it there, the preferred first-line treatment. So you'll see that this table suggests that for a patient in this age group with mild persistent asthma, their preferred first-line treatment is low-dose inhaled steroids. What does that mean exactly, however? And when we look at the stepwise charts, which we're going to go into more detail on shortly, you'll see that the preferred treatment would be a daily low-dose inhaled steroid for these patients with mild persistent asthma at step 2. However, there are alternatives. There's alternatives for only viral-induced wheezing. There's also descriptions as to which relievers you should be using. And so some of you should be saying, why is there a reliever recommendation? If this is one way that we should be treating our patients. And the reason is because the idea is that we should be personalizing our asthma therapy, and we should be utilizing patient-centered care and shared decision-making with the families and with the patients to make sure that we are putting them onto a treatment regimen that works for them, that works for us, and that we believe will actually help to control their asthma. And so the guidelines
Sorry, Dr. Kelly, we're losing a little bit of your audio.
over your meeting them. Oops, I'm sorry. Can you still hear me? So
Now I can hear
the
you.
hope
Yes.
is
We
okay,
lost you for
so
about a few minutes, for a few seconds.
okay, so the guidelines, the guidelines, the GINA guidelines in particular over the last few years have really begun to recognize that personalizing asthma management is incredibly important, and making sure that we are meeting the patients and the families where they are, as opposed to telling them that you have to be adherent with something twice a day, every single day, and there's no other option. So we have to really think about what are the alternatives for our patients and what will work best for them. And the truth is that there is not one size fits all. Asthma management is a very personal topic, and it is something that really requires good conversations and open conversations between the providers and the families to make sure that we are taking the best care of those kids as possible. So this is for 6 to 11-year-olds. Okay, so in the GINA guidelines from 2025 as well as from 2026, they put out these charts as well, which I think are very helpful in a similar way of looking at that symptom frequency, and then if that patient has that type of symptom frequency, what is the medications that you should be starting with. But you'll notice that for a lot of these categories, when it's saying to start with, look at how many ors there are. So for instance, up at the top here, you've got medium dose ICS LABA plus as needed ICS SABA, or plus as needed SABA, or low dose MART with an ICS formoterol. So that just gave you 3 different options for supposedly this one treatment option. That's very complicated. And for somebody who is not necessarily doing this every single day, it can be a huge question and a huge barrier as to what medicine should I be starting my patient on. I think they should be on this, but is their insurance going to cover it? Do we know that that's the medicine that they need? There's so many factors that play into which medications we can actually start our patients on. So GINA, this was new this year, which I really, really liked. And it is a breakdown for the process you should be going through, and what you should be asking yourself as you're trying to choose that medication to start your patient on. So the first question you need to be asking, and this is where those stepwise charts are going to come into play, for this patient, which is the right class of medication, right? And so the stepwise charts are going to show you that. The severity assessment chart is going to show you that. Any of those places are going to tell you that your patient has moderate persistent asthma. They should be on this class of medication. However, for these medications, which inhalers are currently available to the patient? That is an incredibly important question, because here in the United States, this is just a snapshot of most of the inhalers that are available to our patients. As many of you know, even when we're looking at albuterol, there are probably at least another 3 or 4 different colors of albuterol inhalers that I can think of. There are additional new medications that are constantly coming out. We were just discussing with Stephanie that there is a new triple therapy that was literally approved 2 days ago. And so keeping up with all of these new medications is very challenging. And you'll notice that in the controller medicine or maintenance medicine section, this section is getting very big. There are a lot of inhaled steroids, there are a lot of combination medications, there are a lot of triple therapy medications, and then we also have to throw in things like anti-inflammatory relievers with short-acting beta agonists like albuterol, which is in Air Supra up here at the top. And then also we have to be thinking about MART or SMART, that single maintenance and reliever therapy with any sort of ICS formoterol containing inhalers, such as Symbicort, Breyna, and Dulera, which are the 3 that are available currently in the United States. That is the other complicating factor in all of this, is that much of the GINA guidelines were based on, they are global initiatives, so they are global guidelines. Therefore, a lot of the inhalers and recommendations on those global guidelines are not necessarily applicable in the United States because we don't have access to those medications here. They are not FDA approved. Okay, so let's talk about how we decide which types of controller medications you would think about starting your patient on. And so in order to do that, you need to understand what the different options are for controller medications, what the different options are for reliever medications, and why we would even consider doing something other than the first line that is recommended on formulary for whichever insurance your patient has. Because there are lots of different things that you need to take into consideration and many different factors that you need to take into consideration. So we all know that inhaled steroids are the first line therapy for persistent asthma. They are typically used either once or twice a day to prevent asthma symptoms. They decrease inflammation, specifically eosinophilic inflammation, and they help to decrease mucus production in particular. They do have some side effects that come with them, including things like thrush, hoarseness, some immediate cough, and they can decrease the growth velocity, particularly in the first 2 years while they're on them. The dosing of the different inhaled steroids is based on the potency of the inhaled steroid and the patient's age. So from the EPR3 guidelines and in the updated GINA guidelines and in the updated EPR4 updates and from all of the different studies that have come out in recent years, the ALA was able to put together an inhaled steroid dosing chart that recommends, at least for the most commonly prescribed inhaled steroids, what you can start with and exactly how many puffs of each of those different types of inhaled steroids you can start your patient on. And again, this is based on potency and the patient's age. The important thing to notice is that a lot of this data is extrapolated from older child data because these medications are not necessarily approved or they have not been studied extensively in the younger age groups, including the LABAs. Many of the LABAs are not approved for children under the age of 4. However, we all know that there are those certain cases where we will actually use those medications, and we'll think of them particularly in the kids in the 4 to 5 year range. Okay. So which ones are there? So we all know of budesonide, inhalation nebulized, which is brand name Pulmicort. The nebulized medications are very easy for providers, meaning for us to prescribe, because they do not require much education for our patients for how to use them. However, anyone who has ever tried to wrestle a toddler to the ground while giving them a nebulizer knows that nebulizers are not particularly convenient for parents, and particularly for older children, anyone that is not an infant. Um, Asking a patient or a parent to sit with their child twice a day, 15 minutes, while they complete their nebulizer for their controller medication is really not fair, because if anyone has kids at home, mornings are crazy and nobody has 15 minutes to sit down and do a nebulizer medicine every single morning. So many of us, and the general preferred method for especially younger children is prescribing an inhaled steroid that comes in an HFA form. So our two most commonly covered ones by the different insurances across New York State are fluticasone inhaler, which used to be brand name Flovent, but is only available now as generic fluticasone. And of course, mometasone HFA, which is Asthmanex HFA. These do come in different doses, and they must be used with a spacer. The reason to prescribe one over the other, quite frankly, comes down to insurance coverage. New York State Medicaid preferred medication right now for the inhaled steroids is fluticasone generic for all New York State Medicaid. Another option is cyclesinide, also known as Alvesco, which is actually a very good medicine. It is what is called a prodrug, so it is not activated until it reaches the receptor. So that it is actually particularly good for children who have a lot of side effects with other inhaled steroids. Or children who have mucositis, either because they're on chemotherapy or something along those lines, or children who have a lot of behavioral side effects from the inhaled steroids. They tend to do a little bit better with cyclesinide. Cyclesinide is actually the preferred drug, at least it was the preferred drug last time I checked, in Canada. But for some strange reason in the United States, it has not been picked up by many insurances. And so therefore, most insurances do not cover Alvesco. But it also needs to be used with a spacer. A few other inhaled steroids to mention, Qvar, which we all know from a long, long time ago. Beclomethasone has been around for a very long time. Qvar, many years ago, I don't remember how long now at this point, probably 10 years ago, went from an HFA to a breath-actuated inhaler. And it is FDA approved for children down to the age of 4. Unfortunately, it is not reasonable to expect a 4-year-old to be able to use the breath actuated device correctly. And so in general, we recommend that it is not used in kids until they are able to take in a deep inhalation on their own, which would mean over the age of about 6 or 7. It is used without a spacer, and that is very important. You cannot break it apart and take the canister out and stick it into an HFA can, because you do not know what dose of medication you are providing to your patients when you jerry-rig it that way. So it is not recommended to take apart the inhaler. There are also several dry powder inhalers. These are a little bit more difficult to use. They require a deep, fast inhalation. And so therefore, we generally do not recommend that these are used in kids until they are over the age of about 9 or 10. The tricky part is that there are some particularly private insurances in New York that only cover the dry powder inhaler formulation of something like Asthmanex, and they don't cover the HFA formulation. And so they will require a prior authorization if you really want your patient to get the HFA, which if your patient is younger than the age of 10, I am going to strongly recommend that you argue with the insurance to get them the HFA so that they can actually have the medication delivered to their lungs. Our Nuity is just one to mention. This is fluticasone, a dry powder inhaler, and this is a great medicine for the teenagers in particular because this is dosed one puff once a day, which is great for the patients who are perhaps not the most adherent with the twice day dosing. And the other reason to consider the dry powder inhalers, there are two reasons actually. One is for those teenagers who really don't want to use a spacer. And two is that it actually has the lowest carbon footprint because of they are dry powder inhalers, so they do not have the propellant that the HFAs do. Okay. Moving on to LABAs, or long-acting beta agonists. These are indicated for daily use in moderate to severe persistent asthma in conjunction with an inhaled steroid. Okay, so we cannot use the LABAs by themselves for asthma. For COPD, they use LABAs on their own, but for asthma, you have to do it in conjunction with an inhaled steroid, which would be different medications such as Symbicort, Advair, Breo, which we'll talk a little bit more about. Utilizing a LABA, adding a LABA to the inhaled steroid allows you to give a lower dose of inhaled steroid as the controller. So you can think of it as a steroid sparing agent. A lot of patients are able to go down on their inhaled steroid doses because we add on that LABA. And the other really great part of it is that formoterol in specific can be used as a reliever when it is part of either the anti-inflammatory reliever or smart therapy, which we're going to talk more about later. So but we do recommend that if you are prescribing an ICS LABA to a patient who is less than 12 years old, that they should be seen by a pulmonologist or an allergist just to make sure that they are on the correct kind of dosing and that they know how to handle their controller medicine and their rescue medicines, and that they have a good plan to go forward. Okay, so which ones are out there? The three common ones that we use via HFA with a spacer are Advair, which is fluticasone salmeterol, mometasone formoterol, which is Dulera, and then budesonide formoterol, which is Symbicort. The New York State Medicaid approved one is Symbicort, which is here. And as we will discuss further later, the only LABA that is approved for the use in SMART or as an anti-inflammatory reliever is formoterol. So only Symbicort and Dulera can be used as rescue inhalers. The other ICS LABAs can only be used as controllers. And these are typically dosed twice a day for Air Duo or Advair. And then Breo Ellipta, which is fluticasone vilanterol, a different LABA, is actually dosed once a day. So once again, these are the dry powder inhalers, and these should be used in kids over the age of 10. But that Breo can be particularly helpful for those teenagers who are non-adherent. Okay, so we talked a little bit about the different kinds of controller medications, but which of these inhalers can the patient use correctly after you train them? So we talked a little bit about this already. So reasons to give a patient a nebulizer, particularly if they're younger, but quite frankly, if the family insists on using a nebulizer, that's their decision. We as providers, as long as you are okay with giving them budesonide only, because budesonide is our only option for controller medication in the nebulizer, then that is up to the family as to which medication they would prefer to use. The MDI with HFA, as we all know, no coordination is needed when you use it with a spacer, but you do have to train the patients on how to use the spacer correctly. And you can use and these need to be one-way valved holding chambers. It is not just a plastic tube. It actually is a valved holding chamber, okay? Dry powder inhalers, as we mentioned, fast, deep inhalation, and they have to be able to hold their breath for 10 seconds. Very important. The breath actuated, which is QVAR, as well as ProAir RespiClick, which we'll talk about, also requires less inspiratory force than the dry powder inhalers, which is why we can do it for kids down to the age of about 6 or 7, but still requires that 10-second breath hold. We all know why it's so important to use a spacer anytime we use an HFA in order to actually deliver the medication into the lungs, as opposed to having it stick to the oropharynx or go into the stomach. So we recommend spacers with HFA inhalers for children and adults. And I tell every single parent and every single patient this as well. And many of them, the parents also have asthma, and they say, oh, my doctor never told me that. And I said, well, we strongly recommend it, and you can go onto Amazon and buy yourself a spacer and start using it with your inhaler, and you will feel the medicine getting to where it needs to be. So taking a step back, let's talk a little bit more about those changes in the guidelines that have come out between 2019 and 2026, particularly from the GINA guidelines. When we talk about anti-inflammatory relievers, or AIR therapy, as well as SMART or MART, which is single maintenance and reliever therapy. So in 2019, the GINA guidelines came out, and they rocked the asthma world. They turned a lot of our thinking upside down, and they told us that we should no longer be using albuterol, or short-acting bronchodilators, as a rescue medicine for adults and adolescents, for anyone over the age of 12. And so there was a lot of going back and forth, and a lot of people who said, this doesn't make any sense. Why are we suddenly doing this? Especially because there used to be a black box warning on lab buzz, so the long-acting beta agonists, because of the concerns of a risk for death from asthma, because of the studies that they had done in COPD patients who were not taking inhaled steroids at the time of taking Labuz. So that is why it is so incredibly important anytime that you are prescribing a LABA, that there has to be an inhaled steroid with it, along with it. So the reason why the GINA guidelines in 2019 came up with this recommendation of no longer giving just albuterol was that there's this the risk of apparently mild asthma. So patients who had very, very few symptoms in the 3 months prior to serious exacerbations, there were actually 15 to 27% of adults who die of asthma had very few symptoms. They would have been considered mild asthma in the 3 months prior to that death from asthma. And seriously higher numbers for patients with serious exacerbations. Whereas they had many studies over the decade prior that had shown that adding on an inhaled steroid to that beta agonist actually helped to reduce the need for oral steroids, reduce severe exacerbations, and reduce the risk of death from asthma. So this was big. This was a big change to the way we thought about things. So there have been many studies that have been conducted since then. And what we now know is that there is a lot of evidence out there, particularly in kids over the age of 12 and adults, for the use of anti-inflammatory reliever only with ICS formoterol. That really helps to reduce asthma symptoms and those severe exacerbations, as well as for MART, that maintenance and reliever therapy with ICS formoterol, again, reducing the frequency of the severe exacerbations. So let's talk about what our options are for quick reliever medications. Our quick reliever medication that we all know and that has been around for decades are the quick-acting bronchodilators and the beta agonists, such as albuterol. This was the mainstay of asthma treatment for a very, very long time. They relieve symptoms within 10 minutes by relaxing bronchial smooth muscle. Notice they only relax bronchial smooth muscle. They do not do anything for the inflammation that occurs when you are having an asthma exacerbation. And so that is the reasoning behind the GINA guidelines from 2019, saying that giving patients at least a little bit of an inhaled steroid reduces their risk of having a severe asthma exacerbation or death from asthma. This is just a note on the recommended dosing for albuterol. So for small patients under 20 kilos, of 4 puffs of an albuterol HFA with a spacer is the same as giving them a 2.5 milligram nebulizer. And for larger patients, 8 puffs of the albuterol is equal to a 5 milligram nebulizer. So 2 ampules of albuterol in the nebulizer. Because many patients will tell you that they feel better when they use their nebulizer than doing 2 puffs of their albuterol. That's because they're not taking as much of the medicine. Now, the new kid on the block that was suggested in 2019 was that ICS LABA can also be used as a reliever, but as I mentioned earlier, only formoterol. So this cannot be done with salmeterol. This cannot be done with vilanterol, which are the LABAs that are in the other ICSs, the other combination meds. And again, this has to be in combination. So budesonide formoterol is Symbicort, mometasone formoterol is Dulera. And when you're using it as a reliever, it can be used 1 to 2 puffs every 4 to 6 hours as needed, with a maximum of 8 to 12 puffs in a day, depending on the patient's age. We're going to talk more about that too. There are side effects, of course, of all of these bronchodilators, which include tachycardia and some hyperactivity, particularly in the toddlers. So, as we mentioned earlier, these are some of the albuterols that we all know and that have been out there. So the SABAs come in the HFAs. There is one dry powder inhaler called the ProAir RespiClick. So this is not used with a spacer. When you have somebody who insists on using albuterol as their rescue medication, or needs to be on albuterol as their rescue medication, but they refuse to use their spacer, this is a good option. Albuterol also comes in a nebulized form, and then I'll just give a quick shout out to our friend ipratropium, which is actually a short-acting muscarinic antagonist, which is sometimes can help with poorly controlled asthma or an acute exacerbation. And as I mentioned earlier, there are many more different albuterol inhalers. There's a purple one, there's a white one, I just saw a green one last week, and it's very confusing. And it can be very confusing for patients as well as it can be for us. So it's really important when you're talking to your patients about which inhaler do you have at home, that you can't just say that they can't tell you, oh, the red one. Is there red one ProAir or is there red one Symbicort? Is there purple one albuterol or is there purple one Advair? Is the blue one Ventolin or is there blue one Dulera? It's really hard to tell the difference. So it's really important that they're either bringing in their inhalers to the visit or that you're showing them the inhaler poster and asking them to point out what they have. As I mentioned, we have some new kids on the block now. So when we're talking about the ICS LABAs, so for smart therapy or for air therapy, we have Dulera and we have Symbicort, and there are a few others like Breyna, which is generic Symbicort, as well as our latest one that's been added to this about 6 months ago, which is Air Supra, which is budesonide albuterol. And this is great because this is the first time that we actually have an ICS STABA in the United States. Unfortunately, right now, it is only approved for 18 and above. And so this makes things a little bit challenging. So a few other words on the anti-inflammatory relievers. So as we mentioned earlier, the GINA guidelines in 2019 said we should not be using albuterol PRN only anymore. And they have now gone on to say that this is true for children as well, down to age 0, that even for the younger children, that we should not be giving albuterol alone, that we should be including an inhaled steroid whenever we are giving a child a bronchodilator. So the challenge is that the GINA guidelines suggest this, particularly for the younger children, as a low dose inhaled steroid with every albuterol dose as needed. So whenever albuterol is given, you're supposed to also give an inhaled steroid. In the United States, our only option and our only way of doing this is by giving 2 separate medications, 2 separate inhalers, or 2 separate nebulizers at the same time every time that child is going to take an as-needed medication, which is challenging. In Europe and in many places across the world, they have alternatives. They have combination ICS SABAs that they can offer even to younger children. So that's why this is a little bit easier in other countries. In the EPR4 guidelines, they had actually suggested, based on several trials that were done in the United States, that another option for particularly preschool wheezers, that is for mild viral induced asthma, whether intermittent or persistent, instead of doing it this way with a low dose inhaled steroid every time albuterol is given, you can give a high dose inhaled steroid for twice a day for 1 week at the very first sign of a viral illness, along with albuterol as needed. This ensures that the patient is getting a high enough dose of the inhaled steroid to actually give that anti-inflammatory effect, while they are just utilizing the albuterol as the rescue medicine to help calm the cough. So this is something that we maintain here in the United States, and that we have kept in our stepwise charts with the ALA because of the difference in the types of medications we have available here. For older children, the middle-aged children, the preferred reliever is actually a low-dose inhaled steroid with formoterol. So that would be Symbicort or Dulera, 1 to 2 puffs every 4 to 6 hours as needed. But you can also use albuterol as needed if they're not on an ICS formoterol for their LABA. So if formoterol is not their LABA, then you should be using albuterol as their rescue. Or for the younger kids, if it's again that mild viral induced asthma, you can also consider doing PRN high dose inhaled steroids with albuterol as needed. And then in the over 12-year-olds and the adults, the preferred reliever is always going to be a low-dose inhaled steroid with formoterol, but you can consider using a low-dose ICS albuterol as needed if they're not on formoterol as their controller, or add on ICS with albuterol as needed if they're not on formoterol for their LABA. So in this scenario, that patient will have 3 different inhalers. I believe that's a little bit complicated, but every patient is different and you never know what people are going to prefer. So I usually lay out all the different options and then I help the patients decide which one will work best for them. A quick word on SMART, which is now usually called MART, so they got rid of the S. It's basically using one inhaler as a controller every day to prevent the asthma symptoms, and that same inhaler as the rescue medication. This is typically low to medium dose inhaled steroid with formoterol, Dulera, or Symbicort. And you can do the 2 puffs 2 times a day, and then additional 1 to 2 puffs with the spacer every 4 to 6 hours as needed. Of note, in 2026, last month, Gina rephrased the term a maximum of 8 puffs in a day to seek medical care if more than 8 to 12 inhalations are needed in any day. So for kids under the age of 12, it is recommended that the maximum is 8 puffs in a day. For kids over the age of 12, it's 12 puffs in a day. From the GINA guidelines, this is how their stepwise charts look. The GINA guidelines do not separate out intermittent asthma and mild persistent asthma. They put mild asthma all under one step. So typically step 1 is intermittent / mild persistent asthma, if you want to try to go between the two types of guidelines. And this is just pointing out to you how for the 12 and up, they have the different options for air only, particularly in steps 1 and 2, or you can consider air with something like the ICS SABA or ICS formoterol if you're using this in the higher steps, and then where MART comes into play, or SMART comes into play. Similar to what I showed you earlier for the younger kids, the older kids as well, the GINA guidelines have this same breakdown where based on the frequency of your patient's symptoms, they suggest a preferred first-line treatment, and that is what they call track 1, or their alternative track is track 2. So you can look at this in more detail if you'd like to see where things differ from our Breathe New York stepwise charts that were updated in 2025 to reflect all of these adjustments in particularly the GINA guidelines over the last few years. As I mentioned, the reason why we decided to keep our own hybrid charts of those GINA guidelines with the EPR3 updates was because of the availability of the different kinds of inhalers in the United States. So as you work your way through the different stepwise charts, and there are 3 stepwise charts based on age, so you can see here that in the 0 to 4-year-olds, step 1, which is intermittent asthma, even for intermittent asthma, it is recommended that the patient receives some inhaled steroids when they are sick. So they can either do the high-dose inhaled steroids such as fluticasone 110 micrograms, 2 puffs BID for 1 week at the first sign of a viral illness, along with albuterol as needed, or they can take a low-dose inhaled steroid such as fluticasone 44 micrograms every time, 2 puffs every time albuterol is given. Okay, and then you work your way up the steps so that a patient with persistent asthma, the preferred first-line treatment is always going to be a daily inhaled steroid. But for mild persistent asthma, the alternative now is that PRN inhaled steroids only with illness. And then you'll notice that that even now in the step 4 in the young kids, the preferred first line treatment is actually an ICS with a LABA. So these the stepwise charts recommend, based on the guidelines, that the even young children be started on an ICS LABA if they are in the severe asthma range. This is really important because these are not necessarily FDA approved for this age group, but you can argue to get them approved by the insurances for these children because this is these are the medications that we know will actually help get them under better control. Okay. In the 5 to 11-year-olds, a couple things to notice is that we have also maintained that for intermittent asthma, you have the option of using that high dose inhaled steroid with albuterol as needed. And we have kept that the same for the 5 to 11-year-olds as we did for the younger children in mild persistent asthma, because we know that there are a lot of kids who are in that 6 to 7-year-old range that really only have that viral induced wheezing a couple of times a year. So for those kids, it is reasonable to try this. And if they are having symptoms in between those viruses, that's when you should be going to the preferred daily ICS. Notice also that in this age group, we are starting inhaled steroids with LABAs at an earlier time. So even in moderate persistent asthma, the preferred first-line treatment is actually a combination medication. It is not going up on the inhaled steroids. So this is really important. We know we want to really try to avoid using high doses of inhaled steroids in our patients. Okay. In the older ages as well, as you can see, as patients get more severe, we also add on additional therapies such as the LAMAs, which I will mention in a moment, and we are also considering asthma biologics, which many of them are approved for kids over the age of 12, and there are a few that are approved for children over the age of 6. So for the 12 and up, we have many more options for medications that we can use for them, just from an FDA approval perspective. And you'll notice that we have at the top our preferred track in blue, and then the alternative track in green, mirroring what they do in the GINA guidelines. Notice that here we have the option of the ICS SABA combination, which would be Air Supra, as a reliever medication. So notice that down here in the green area, the alternative reliever is albuterol alone or that Air Supra as needed, if the patient is not on a formoterol containing combination medication. Okay. If they are on a formoterol containing controller medication, then the recommended reliever is that ICS formoterol. All right, a few words on other medications. The LAMAs are used as for patients typically over the age of 6 with moderate to severe persistent asthma that is poorly controlled on ICS LABA therapy, and we would add it on. There are, so Spiriva is a LAMA that you can just add on to whatever they're taking. And then there are now 3 medications that are triple therapy, ICS, LABA, and LAMA, including Trelegy, Breztri, which is this yellow one, and then this brand new one, Trimbow, that just came out 2 days ago, I believe. We tend to use these more in patients that have more COPD-like symptoms or that severe asthma phenotype that is really not well controlled with just an ICS LABA. Quick word on leukotriene modifiers. If they're not already on Singulair, please do not start it and consider stopping it because of the black box warning for behavioral side effects and the associations with suicidal ideation in teenagers. It is a very weak anti-inflammatory effect compared to the inhaled steroids, so it is not particularly helpful as an asthma controller. It is a good allergy medicine, but I would not use it as an asthma controller. You're much better off with the inhaled steroids, the LABAs, and the LAMAs. Quick word on biologics. We can't talk about asthma without talking about biologics anymore. There are a lot of them out there. And this is something where if your patient has moderate to severe asthma, particularly eosinophilic or allergic type asthma, there are many options for them for biologics, which are game changers in asthma management. patients who have non-allergic asthma, we do also have a couple of options for biologic agents. And the latest one that just came out in January is actually dosed every 6 months. So it's 2 shots in the year, and it significantly reduces asthma exacerbations, as do all of them, as well as help to improve asthma control. The GINA guidelines also give some suggestions for ways to choose your asthma biologic and how you can assess for a good response. So once you have decided which medication you're starting your patient on, you need to be assessing their control, and you need to figure out if that patient is actually happy with that medication, if it's working for them. GINA guidelines also mention thinking about that environmental impact, which I mentioned to you is not really an option here in the United States because a lot of the medications that exist as dry powder inhalers in Europe, we don't have here in the United States, but that is something that you can factor into your decision making. You assess asthma control once your treatment is established. You consider their current impairment and future risk domains, and you want to be doing this at periodic follow-up. You can use things like the asthma control test in order to do this. And once control has been maintained for at least 3 months, you can consider stepping down therapy in order to identify the minimum amount of medication, particularly the inhaled steroid component, to maintain control. You want to be mindful of seasonal triggers, so you don't want to be stepping down a patient when it's the beginning of their spring allergy season. You might want to wait till after the spring allergy season. You also want to consider referring them to a specialist if they are requiring these more advanced medications, if they're requiring higher steps in medication. The NHLBI actually suggested that you consider a consult for pediatric patients with mild persistent asthma, and that it is actually recommended for pediatric patients with moderate to severe persistent asthma. This can be a pulmonologist or an allergist. Severity can be adjusted. It is defined by the minimum amount of medication needed to maintain control. So if a patient is requiring consistent step up in their asthma, their asthma management, their asthma therapy, their severity also steps up. But if the patient has been well controlled for more than a year on a lower step of therapy, then you can actually lower your diagnosis of their asthma severity as well. As I mentioned, the GINA guidelines in 2026 that just came out last month talked a lot about personalized asthma care, so that when you are thinking about, treatment level options at a population level, we really want to be thinking about what access patients have to those medications. And so that's why we have worked so hard to put these stepwise guidelines together for our ALA members who are interested in what we can do for our patients here in the United States. And we really encourage you to participate in that shared decision-making with your patient and the caregivers to talk about which medications do they prefer, what other characteristics and phenotypes of the patient do you need to be thinking about when you are prescribing those medications, what are their goals and beliefs, and what are their concerns about asthma treatment, and then what practical issues are there? Can they use the inhaler? Do they need to use a spacer, or can they use a dry powder inhaler? Are they using it correctly even after you train them? Can they afford the medicine? Will their insurance cover it? And will they adhere to it if it's twice a day? Or do you really need to put them on something that's once a day? And is something like environmental impact something that's important to them as well? I do have a quick case presentation, which I don't think I have time to go through, but the gist is that you decide that the patient needs to be on MART therapy, so you fill out their recommended asthma action plan, and there's a couple of different versions. So this is the one that is suggested by the GINA guidelines. This is the one that we have available to us at New York Presbyterian. And what you can see is that their rescue medicine as well as their controller medicine is that Symbicort, which is really important. So in summary, our stepwise methods and consistent assessment of severity and control can be utilized with all asthma patients and should be utilized with all asthma patients. Inhaled steroids really are your first line treatment for controlling asthma, but additional therapies such as combination LABAs, LAMAs, and biologic agents should be considered to minimize that inhaled steroid dosing. And you really want to be thinking about anti-inflammatory relievers and single maintenance and reliever therapy because they are key in treating pediatric patients with both intermittent and persistent asthma. Thank you, everyone. And if anyone has any questions, you can pop them into the chat, and I'm happy to stay on for a few extra minutes.
Thank you so much, Dr. Kelly. Such an informative webinar. So thank you so much for your time and such a great webinar today. So we did have one question. I know we're over time, but I'll ask it now. And of course, I understand if some folks do have to jump off, but Cindy did ask in the chat, can you please share a step-by-step example of how to use SMART when symptoms occur and how to best write an asthma action plan? For example, 1 puff, wait 20 minutes, and repeat up to X number of times, max dose daily X.
Okay, so that's a great question. Thank you, Cindy. So I'm actually going to go back to this. So this is how you would fill out an asthma action plan for somebody who is on SMART. So what they should be taking every single day is their budesonide formoterol, 2 inhalations in the morning, 2 inhalations in the evening. That's their green zone. Their reliever is the budesonide formoterol, and as it suggests here, 1 inhalation whenever needed for relief of my asthma symptoms. So if over a period of 2 to 3 days, their asthma symptoms are getting worse or they're not improving, then they will continue to use their regular everyday treatment plus 1 inhalation of budesonide formoterol whenever needed to relieve symptoms. If they are needing more than 12 inhalations in a day, they need to be contacting their physician. So there are different specific directions on how to do it exactly. So you can start with 1 puff of, for instance, Symbicort, and wait 20 minutes. And if you are still feeling symptoms, then you take a second puff after the 20 minutes. The other recommendation, which is the way that we have it written on the stepwise charts from the ALA, is that you do 1 to 2 puffs every 4 to 6 hours based on the patient's age. So under 12 gets every 6 hours, over 12 gets every 4 hours. I personally find that most patients can understand those instructions a little bit easier than take a puff of Symbicort whenever you feel like you need it, because they don't always keep count of how many puffs they've taken. And so it can get challenging to make sure that they're not overdosing, that they're not taking more than the 12 puffs in a day. Also, most of our asthma patients are very used to the idea of taking their albuterol every 4 hours as needed. So that concept of every 4 to 6 hours as needed is well ingrained in many of our asthma patients, so that trying to align SMART therapy with the way that they always knew how to take care of their asthma makes things easier for them in general. So typically, I will suggest take 2 puffs every 4 hours. And if you are needing it more than that, or if you're needing it 2 puffs every 4 hours for more than a day, you need to call me. I hope that explains.
Thank you so much, Dr. Kelly. Okay, perfect. So please join us on our next webinar. This is our final webinar to end Asthma Awareness Month, and 0.5 continuing education credit has been approved with a live attendance. So you can scan that QR code or also visit us at our Asthma Awareness Month at the American Lung Association landing page. You can also register there. That's going to be next Friday at 12:15 Eastern Standard Time. Again, thank you so much, Dr. Cowley, for everything. Thank you all for joining us this afternoon, and I hope you have a wonderful long weekend. Thank you so much.
Thank you, everyone.
Thank you.